All right, let's go ahead and get started. If folks could either, if you're finishing up other conversations, if you want to step outside or if you want to find a seat, that would be great. All right, last day. Hopefully folks had a good time last night at the reception gathering. Went later than I would have thought, which was great. So, good morning. I'm Dr. Viet Nguyen. I think most of you have met me by now, and if you haven't met me in person, please come up and say hello. Today, at this session, I'm going to talk about the role of FHIR in burden reduction and prior authorization, and this work has been sponsored by the HL7 Da Vinci Project. For those at home who haven't been following everything here on site, I'm the Chief Standards Implementation Officer for HL7, and prior to that was the Technical Director, and still support the Da Vinci Project as the Technical Director. So for this session, we're going to talk about a little bit, very briefly, about Da Vinci. So for those unfamiliar with Da Vinci, we're going to talk a little bit about what do we mean by provider burden, or at least a small segment of provider burden. And we'll talk about prior authorization and why it is considered so burdensome to clinicians. And we're going to use a clinical scenario. And then with that, I will lay out what the Da Vinci work has done and what we see the vision around reducing burden through prior authorization will be. So just briefly, the Da Vinci Project is an HL7 FHIR accelerator. We don't have a discussion here about accelerators, but it's really a collaborative brought together under HL7 to identify important workflows. Da Vinci was one created by the provider, payer, and vendor community to focus on value-based care and fee-for-service workflows and introduce or identify opportunities to use FHIR to improve interoperability between providers and payers. And really the goal is to use FHIR so that we can exchange data more effectively. We have a number of use case and use case categories within Da Vinci, anything ranging from clinical data exchange around like attachments or referral information using FHIR, which we won't be talking about today, but just is in the middle of a ballot reconciliation. We have some work that's already in regs around payer data exchange, and we have some significant work that was started around quality that was continued by the FHIR community and the HL7 community to advance exchange of quality measures. This is our roadmap for Da Vinci for this year. We are in the midst of a ballot reconciling a number of our guides, including these burden reduction guides and the clinical data exchange guides, and we expect to put a few more guides back into ballot for updates, particularly around member attribution, and then hopefully get a number of them published by the end of the year, early next year. So let's use a clinical scenario. How many clinicians do we have in the room? By raise of hands. Okay, one. Developers? Almost everyone? Okay, so I think it's helpful for the developers to know what are you helping solve. So this is a common scenario that pretty much every clinician is familiar with, but it's a fictitious example. Mr. Albert Washington, 57-year-old African-American with a history of controlled hypertension and chronic migraines, presents to his primary care physician, Dr. Goodhart, with a change in frequency and character of headache. Dr. Goodhart does his evaluation or her evaluation and determines that the patient should have a head MRI. For the clinicians in the room, just assume that all the criteria clinically is met. But typically, I mean, in the office, when I see a patient like this, I have to ask 3 questions that come to the core of why we're doing this is, does Mr. Washington's health insurance require prior authorization? I have no idea, first of all, unless I look in his chart what insurance he's on, and I certainly don't know what his coverage is. Next is, okay, assuming that it does require prior authorization, do I have the documentation I need so I can get that authorization done? And then number 3 is, what is the process I need to do prior authorization? And each of these steps creates a burden for the clinician or their back office staff, delays care for the patient, and often can be a barrier to care. So we're going to totally separate out whether or not a patient deserves to have a prior auth approved or not, and focus on how do we get to that point to get care approved. So let's talk a little bit about administrative burden. So this was an article published by the American College of Physicians. It's a professional society of internists. that really concluded a number of things, and it's probably worse today than it was when they published this a few years ago, which is that clinicians and their staff spend 3 to 5 hours a week doing work related to billing, insurance, and as well as quality measures. And they're not doing that while they're taking care of patients, because taking care of patients is their primary concern. They're doing it after hours, on their day off, in the evening time, on time that they could be spending with their families or doing other things outside of their work. So we call that the kind of the pajama time. Also, there's a significant amount of expenditures for each provider, not just them, but all the individuals within their office and their organization helping them with their administrative duties. So somewhere between $68,000 and $85,000 a year per physician FTE dealing with these administrative tasks. And prior authorizations, I think this is actually very conservative, could cost around $3,000 a year per physician in taking care of. And it really varies between physicians, because if they're a physician who does a lot of procedures, they might actually be doing a lot more prior authorizations than one who's a primary care doc that I might do one or a handful in a given week. But each of these burdens reduces in stress for the providers, and the requirements for regulation and their payers, different rules for different payers, increases this burden and causes stress and burnout. And so the American College of Physicians, their conclusion was really needed to facilitate the elimination, whenever possible, reduction, alignment, and streamlining of these tasks, and using health IT to develop innovative approaches to addressing these so that we can reduce this burden. The reality is clinicians have already too much information. They're expected to see a lot of patients, and there just isn't the time and the resources they need to both deliver care and fulfill all these administrative requirements. So with that, there is the federal response in the US around this, and there is a burden reduction office in CMS focused on activities to try to address these, and prior authorization is one of them. This is an announcement back in December 2020 of NPRM around burden reduction that they released and gave about 30 days to respond, which is really short, and then they published a final rule that was actually pulled back by the current administration for reevaluation. I bring this up because this rule gives us some insight on how they want to address this. Medicare and Medicaid, the CMS really has purview over the federal programs that pay for care, like Medicaid, Medicare, CHIP. But where they did not have in this plan were the Medicare Advantage plans. And so because of the short kind of review period and response period. So they really focused on a number of activities. They have what's called the Document Requirements Lookup Service, because Medicare doesn't do prior auth per se. You have to have documentation in case you ever get audited. But also looking at how do you submit claims, making sure that the providers and the patients know why prior authorizations are denied. I think that's not always clear. And trying to shorten the time frame for prior authorizations, and getting better metrics on how many PAs are submitted, how many are approved, so that we can do a better job. But the idea here is that rule was put on hold. But we in the Da Vinci community think that we'll probably see some version of that re-released, maybe this year, maybe next year. I can never say, because we can never tell. So we're hoping to see something, but in the meantime, the Da Vinci Project has always felt that prior authorization was an important aspect of reducing burden for clinicians. And so we identified and brought our community, as well as the broader healthcare community, the HL7 community, to develop 3 implementation guides. One's called Coverage Requirements Discovery. The second is documentation, templates, and rules. And the third is prior authorization support. And each of these address those 3 questions that I mentioned earlier. And at a very high level, there are these 3 components. And they fit inside the workflow. So that's key if you're a developer. You try to not break clinicians' workflow. So we try to put these inside the clinician's workflow using CDS hooks and Smart on FHIR. And the first question and the first guide, the CRD, really addresses this first question. Does Mr. Washington's health insurance require prior authorization for this study or procedure. And the way we do that is in the midst of the clinician creating an order, and we're still trying to sort out a little bit around the CDS hooks work, but we have some CDS hooks that have been defined around the order process. But when they go to order a service, behind the scenes, the CDS hooks identifies the service, takes the patient's coverage information, that payer, to identify the right CDS endpoint to reach out to that payer and exchange that information around the patient and the service to determine if the service is a covered service or not, and return a card. And that card would say that if it's not required PA, then we won't even, ideally, even interrupt the provider. They just continue on the process. But if it does require PA, then we want to, or documentation, we want to let them know so that they can launch an app. And launching a Smart on FHIR app is the current mechanism we're doing, because that would work in any EHR that supports, ideally, any EHR that works with Smart. But we also have a number of EHRs who want to work on trying to integrating this into their platform so it looks more seamless to the provider, which I think is a good thing too. But at a baseline, we give a link to open the app, and within, so we'll start here with the CRD. So the idea here is really, we want to trigger it within workflow. We want to use available patient data along with the prior auth rules around coverage that the payer knows. And that's very payer specific often, and very patient specific because it depends on what health plan they're on. So by providing this back to the clinician and saying, oh yes, this actually does require additional documentation if they're, say, a Medicare patient, or additional documentation plus a PA if they're kind of a commercial patient. That's really useful, because otherwise I would write the order, I'd send the patient off, and I find out a day or so later that, oh, by the way, they need a PA, and here are a bunch of forms you have to fill out. So that's helping reduce burden that way. But really, we want to take the guesswork out of finding that coverage, specific coverage information. We're utilizing the CDS hooks, so that's where, if you're not already familiar with CDS hooks, that's important for you to be familiar with. We want to make it part of the clinician's workflow. And what we also realized in this work is sometimes the clinician may not have everything available, but we want to try to finish as much as we can in the session with the patient in front of us as possible. And for the clinicians in the room, you're probably going to say, well, you're going to add time to my visit. And I say, we're going to try to minimize the time we add, but you're already getting interrupted. You're getting interrupted when you're charting at the end of the day, and when your medical assistant comes to you and say, oh, Dr. Nguyen, you saw Mr. Washington today, and you didn't fill out all these forms. And by the way, he needed to have some additional studies or labs done, and we have to bring him back before we can even submit the PA. So it is maybe just a little bit of burden up front, but hopefully reducing a significant amount of burden on the back end for office staff and the clinicians. So the idea too then is we keep you in the workflow, and we ask the next question. Okay, PA is required. What do I have to document? Because for each service for prior authorization, there's typically information that the payer needs to make sure essentially that the provider has done what they need to do, that it's medically appropriate. And ultimately, there are all other kind of mechanisms that others are working on to try to minimize and eliminate PA, but let's assume that we have to do it here, and I have to do some documentation, so I can then launch a Smart on FHIR app through the CDS hooks card that is returned. And that app combines the use of questionnaire as well as some CQL rules in the back end that comes from their payer, or often a payer's vendor who has these rules built in already, and then starts to retrieve that information. And that's another point of burden. The clinicians say, okay, I got to find these studies, I got to gather and fill out a form around the conditions and any labs, and that's just gonna take time, either my time as a clinician or my back office staff. But if we can use FHIR through Smart on FHIR, we can start to retrieve these using the rules and using CQL, which saves on data gathering. It's not going to be 100% all the time in structured rules or structured data, but when it is available, let's use it, and then we can augment it if necessary with additional information. In this most recent update of the guide, we also enabled the ability to do adaptive forms, so that the forms are there's more of a back and forth with the payer in the back end, so that once you reach a point where you've gathered enough information, it stops asking you for more information, and allows you to do those tree walking when it comes to questionnaires. So again, this is kind of high level. The key here is the use of CDS hooks, the Smart on FHIR and the Smart on FHIR app launch, the use of CQL in rules that the payer has or they use their vendors to have to retrieve data, present it to the provider who can then confirm it and augment it if necessary, and then we store that information because everyone always wants to make sure that they have some evidence that they did what they were supposed to do. And so we store that information, and then so the benefit here is that we're really reducing the burden by automating the data gathering. And it's based on the rules, it's based on FHIR technologies, and we recognize, though, as I mentioned before, you may not have all that data. Let's say that prior authorization requires another additional study or a lab. Then you want to try to get that initiated while the patient's there and not lose the opportunity when the patient leaves. And then you have to get them back, which then lowers the likelihood that you're going to get done what the clinician already believes is the right thing to do. So trying to speed up the process for delivering that care. So then the clinician says, sure, I have all this information, and historically I fill out the form and I hand it to my back office, and they have to submit it typically to some payer portal or one or many payer portals, because even though there is an X12 transaction, it's not really being used very much. And so now the back office has to monitor a bunch of portals and watch emails and submit more data if necessary. And again, all these are delays and more activity that the back office has to do. So we want to make that the process more efficient by allowing the system, the EHR, the provider system, to take that the bundle of information, the documentation information, and create a prior authorization request and submit that to the payer. And in the model that we have for today, they can create a claim resource using all the data they would need for the X12 transaction. So there's some intermediary who takes that transaction and populates an X12 transaction, takes the data, and then sends it to the payer, and the clinical information is part of the attachment's payload. We were fortunate in Da Vinci to be one of the few groups who have ever gotten an exception from CMS to not have to use the HIPAA-mandated transaction. So we are actually gathering a bunch of payers and providers to really pilot this as a pure FHIR approach. Gathering the data in FHIR, submitting the information in FHIR, getting the response in FHIR, keeping the X12 data, but not necessarily having to use the EDI transport mechanism. So I think that could be a real game changer as we transition, or we recognize that there's an opportunity to transition from an EDI approach to an API approach. So really here is a good example of how we are working with the X12 community. We have mappings between X12 data elements into the FHIR profiles for claim to support this, and that mapping is still X12 intellectual property, but through an agreement with X12, they're allowing developers who want to test this to be able to download and use it for testing. You just can't use it for production, and it's probably going to get updated anyways. But that's a good example of really the standards organizations trying to work together to advance the state of the art for the community. And it's because we've started to develop this approach around using FHIR for capturing and creating clinical information through FHIR bundles. This concept of using FHIR as an attachment extends to the broader concepts of attachment, which we also think there might be a rule this year from CMS. And we think there's a lot of value that as there are things that you do in PA that use a lot of structured data. A good example might be oxygen, getting supplemental oxygen. If you look at CMS's documentation, others, it's very structured. It's diagnoses, pulse ox, things like that the provider can get a more rapid response, and ideally a real-time response for the more common, more straightforward services. We're not going to tackle all of PA off the bat, but we wanted to look at the high volume and the PAs that require a lot of structured data, because if we can lower that burden, everybody benefits. So we want to get the providers to be able to get that data and the resolution back as quickly as possible. They can then proceed with the study or procedure, or they can initiate the appeal as quickly as necessary. So important with everything in FHIR that we do testing. So we've had several years of Connectathon testing around this, and we had this the recent one in May. But I want to highlight that we are also going to be participating in the CMS Connectathon. And so if you're a developer and you are working on this activity, let us know, because we're looking for folks to come and do more testing and demonstrations at CMS. It's not going to be your typical Connectathon where we're testing the guides and finding the errors in the guide. We may find errors in the guide, so that's not necessarily a problem, but we want to focus on where are folks today and organizations today in implementing these guides so that we can further promote this to the broader community. So if you want to participate, it is free to participate, but we are really looking for organizations to participate. So with each of these guides, we have a number of developer resources. If you have not already gone to HL7, gone to the FHIR link, find the Connectathon, each of these tracks have a page, and on the page, we have links to the implementation guide. We have reference implementations to the extent that we can make them as real world and high fidelity as possible. It's really hard when you're trying to represent back-end systems that are already pretty complex. But we have support and develop some reference implementation code that you can download. We work with Aegis, who's one of our contractors in Da Vinci, to develop test scripts. And so we're always looking to improve those test scripts and use those in testing. And then we have a couple of calls every week around burden reduction. We just combine them all together on Wednesdays and on Fridays so that the implementers, as you're working on this, you come to the calls and we actually address the implementer questions first. So if you have a question around it, we have the use case leads, we have Da Vinci members who are implementing this. They can answer your questions right away. Of course, we have Zulip and other channels too. And then when we're done with those, we do our ballot reconciliation work. So each of these guides have these resources, so you can look at them I will upload them right after. And we want to invite you to join the community in this discussion. I think this is a huge area for work in healthcare. This burden, prior authorization is fairly U.S.-centric. I'm sure other countries have something similar, but probably not as burdensome as in the U.S. But I think this is a great opportunity for us to come together and support the provider community around this. And we have a number of Zulip streams, but these are the 3 that will be linked for these guides. And then you can always find out more about what's happening in Da Vinci by going onto our Confluence page. It's a link right off of the HL7 confluence.hl7.org page. It's on the right-hand side. You land here. You'll find a number of slides. I'll probably want to post these slides there too. But you'll be able to find an implementation guide dashboard on the right-hand side, left-hand side navigation that you can find links to all these guides. We also have an implementer page that I'm not sure I put in here. I didn't put in here, but we have an implementer page where you can go in, you can find these resources again, and links to the other FHIR technology, like educational things for CDS Hook, Smart on FHIR, other activities to help you get started. And then every other Thursday, it's also linked off that implementer page, is a link to an office hours. So we have the folks from Aegis there on Thursday afternoon just to answer questions. They're there. We're sponsoring this through Da Vinci because we have a lot of folks coming in. But if you're interested in testing, you're part of the other accelerators, or you just want to learn more, they're there. I would say come in at the beginning because I told them if nobody shows up a quarter after, you can go home. So come in at the time they start, and feel free to ask your questions. And I think we need to grow our testing community, testing artifacts, and look at the opportunities we can do that more. So with that, I'll pause for questions. Any questions online? Sure. So this is that link to that implementer support at the bottom. I didn't realize these had a build or automated forward. So, okay, question?
Viet, thank you so much. Great, great content, and I think as you outlined, prior authorization is such a huge burden, such immense opportunity for it. Given the size and scope of the problem, well, I don't say problem, opportunity for burden reduction. You mentioned oxygen as being kind of one of those places where you could think about getting structured data and being able to really streamline this so that it's a real opportunity to almost remove a large portion of the process for a particular use case. Are there other like high volume and kind of low hanging fruit use cases that Da Vinci has thought about that are kind of that places to get started for prior authorization?
Yes, actually on the Confluence, the use case page for burden reduction. So if you go to the Da Vinci homepage, on the left side navigation is a link to the use cases. If you go to burden reduction, you'll see that there are a number of children pages, and one of them are examples. So I don't know if this has been generally socialized to the community, but many of the Da Vinci guides are framework guides. Mm-hmm. They give you an approach to doing things that go across different specialties. Quality measures, an example. It doesn't. We have some examples in quality measures, but we don't do all the quality measures because we think that there are additional guides around content that give more specificity. So the goal with that example set was to identify those more common examples. I think imaging was one of them, and another example would be around oncology. I don't recall the specific PA, but it's an example of the Da Vinci community working with the Codex community that's focused on oncology to figure out how we can combine the efforts with Codex and Da Vinci PA and have those communities work together. And we expect that we're going to have more of those collaborations in the future with the other communities because, like, it would be good to work with not only the payers to look at what needs PA, but the specialty societies, because ideally those PAs are based on good clinical practice, right? So, I hope that answers your question.
No,
so yeah, so go to Confluence. There's probably more than a wealth of information in Confluence, and we try to make it as navigable as possible. So yes, question online?
Online question. Yeah, online question. Are we seeing this adopted as CMS and ONC certification processes for vendors?
That's a really good question. So it is not a requirement at today. However, ONC put out an RFI, a request for information, earlier this year, and I believe the deadline was the end of March, if I remember correctly, and a number of communities, including HL7 Da Vinci, responded to them. And one of the areas in the RFI is prior authorization and certification around prior authorization. Is it, what's the benefit, what are the gaps, what are the challenges, and what would be some of the opportunities for testing and certification around those capabilities. So it's interesting because most of ONC's stuff is around the technologies for providers, and this would potentially expand some of that with payers as well. So yes, there is work there. So yes, sir.
Yeah, no, thank you. This is great, and obviously would make my life easier, so I appreciate that. My question is about the data discovery piece. So a lot of it is kind of within house. So once you know the requirements, you can look through your data and create the forms or whatever. And so that part I feel like I kind of have a handle on. Trying to get the requirements from the payers, I feel like, again, I'm a little jaded, but I feel like they generally do what they can to prevent me from doing any of this easily. What has been your experience trying to get that data from them in order to be able to create the prior authorization?
So I will agree and try to describe what you're saying. Is like, I could actually find out what the documentation requirements are, but I have to go to the payer's website, have to have some sense of the patient's coverage, which I may not be able to easily find on a payer's site, and then often can download a form. And that form tells me what I have to capture, but it's not, sometimes it's very specific, tell us the diagnoses, but sometimes it's a narrative, like send your clinical information along with this. So the hope would be that we have had agreement from the payers that they should expose the documentation requirements. It's a whole different thing when it comes to the coverage rules, because that's often the realm of their vendors, and it's often proprietary, and it's really complex to put together. But one of the things that the payers will need to do is if you are denied, they need to be able to provide transparency to the provider as to why they were denied. So, so there's, I should have called that out. There's the documentation rules part of CQL, and then there's the opportunity if payers want to use CQL on top of that FHIR data to do CQL, and I know that there are vendors who are doing that, or they just use the data and process it however they think necessary to process the authorization. So, Josh?
Yeah, so really important problem area, and then also just like there's a lot of complexity to being able to describe things like rules and requirements in a computable way and getting people to buy in, and especially if they don't have to, like, or maybe they can come close, but they don't quite close it, and so they describe part of the story, but if you only describe part of the story, you really haven't, anyway. So there's a lot of complexity here, and I'm wondering whether there's some piece of like low-hanging fruit that we all know we could definitely solve. Like one candidate might be, people waste a lot of time trying to figure out if prior auth is needed when the answer is no. But like, they still have to fill out forms and look stuff up. Like, is that maybe like a small slice of the problem?
That's the first step.
And is that working? Like, do we have places where that has been deployed and we know that that is successful at that small stage?
Yes, so there are already production pilots of this. Our friends in the Pacific Northwest, Multicare, Cambia, and Providence, I believe, they've done a number of presentations where they've showed they're putting this in place with one of the vendors, MCG. So when you say the low-hanging fruit, there's the process low-hanging fruit, the do I need a PA or not? So that's already built in to that CRD.
So their demo that I saw, if I understood it right, they have a team of 100 people who pull items off a queue one by one and check to see if prior auth is needed.
Right, so the key is to actually be able to link what's being ordered to the coverage information. So the gap may be that they don't even have that in a computable way yet, but that's on the payers. That's on the payer side if they want to do it, right? So the other thing with low-hanging fruit are, and I've recommended this in conversations with the regulators, is let's not make this a requirement for everything in PA. Because if you're looking at oncology even, that's really complex. What are the things that are most amenable to structured data and lower or maybe high volume that we could identify to try to address first? So I don't want to give you some sense that this is going to solve the world, because there is a lot of complexity here. Representing coverage rules in a computable way is really hard because they're made for humans to read. And so there are teams of folks, and some of the vendors here can talk to you about it, that are trying to do that work. So where the data, the documentation data, we need to have the coverage data computable, then the documentation computable, and then the coverage rules, not the coverage rules, but the adjudication rules is a whole nother area.
Awesome, thank you.
Yeah, so I totally recognize that. So I'm not pie in the sky kind of view. Yes.
This question is also from Huva. It's very tied into what you just said, so maybe you want to elaborate, but I think it's answered. I think the prior auth should be required for elective services, but shouldn't a diagnostic scan that is needed to treat a patient have an auto approval or significantly streamlined approval process?
So I would answer in general yes, but in order to say yes, it's if you have certain things in place. So payers have this notion already of gold carding providers, because those providers have been recognized that they follow best practices really well. There are certainly studies that don't need any prior auth, like a chest x-ray, because someone's having shortness of breath. You don't typically need a prior auth for that. But typically prior auths are put in place for things that are really expensive, like a head MRI or a chest MRI. And so until we get to the point where we clearly are already practicing really great medicine, and not just the patient says, I'd really like a head MRI, there's that balance between utilization and balancing, making sure that best practices are utilized. So imagine a day where this is pie in the sky. There's good relationship payer and provider where you can actually track provider behavior beyond what they're doing today. You can look at the patient's data more deeply than what you would just do as CDS hooks, and you already see that the patient and the provider have followed good practices, and you auto-authorize. But in order to get to that day, we need a heck of a lot more data, and we need to be able to represent those rules really well. But that's the hope, because on one side, the clinician says, I'm doing the right thing, just don't make me do the prior auth. And on the other side, the payers say, yes, many of you are, but there are not that may not be following best practices and are overutilizing services. So that's the push and pull that I think data over time will help us to resolve. Another question?
Would you be willing to give background and speculate on potential outcomes of the upcoming NCVHS meetings about the use of multiple standards for administrative data exchange?
I am going to punt on that one because it's happening literally right now, and I was either fortunate or unfortunate to not have to sit in front of NCVHS because I already had this scheduled. So we have some folks from Da Vinci and from our members actually I don't know. I don't think it's actually giving testimony, but they have an all-day panel today talking about it. But I think I will state though that the days of administrative data lives over here and clinical data lives over here are going away, and causing a new problem of ICD-10, CPT, and SNOMED and LOINC over here. So we're going to have to learn how to play well together, and that's going to be a challenge. But going back to the purpose of Da Vinci, the value-based care is really going to bring it all together, because we need this data, because we all want to deliver good care. We want to make that care delivered efficiently and with the lowest cost and the highest best outcomes possible, and we want to spend the least amount of money. And we don't want, I think in general, we don't want regulators to do more than they feel like they have to do to make that happen. So value-based care is really where I see the Venn diagram come together that FHIR and interoperability really supports.
Do you have time for one more?
Oh, yes we do, please.
So the upcoming that pricing transparency mandate, can we sort of combine that with some of the the pre-auth so that patients
Yeah. So I'll tell you my Viet's party line on that, which is they are interdependent but separate enough paths that I can't link them together coherently, but they have to come together at the time the patient, right before the patient gets the service. If I link them, couple them too closely, we know that the cycles for prior auth could be data, could be any number of things, but in an ideal world, ideal future world, when the provider goes to order or schedule a procedure and a service under the PCT, patient cost transparency, they will have also done the prior auth things. And if we can minimize the data gathering, all the burdensome things, they will have already gotten adjudication before the patient goes to schedule the service. So in that ideal world, they're linked, but in a better way, like prior auth's already done. But today, that's not going to happen, and PCT's regulatory compliance deadlines are much sooner than, of course, anything we know, because we don't have any deadlines for PA. We're good? All right, thank you all. Thanks for being here, and I hope you're enjoying your Dev Days, and if I don't see you, safe travels home.